Thank you for joining us this morning. It gives me great pleasure to introduce our speaker for today, Haley Fitzgerald. Haley is a neurosurgical PA extraordinaire. She's the co-creator of the GNI Center for Chiari and Center. She earned her Bachelor of Science in Behavioral Neurosciences from Lehigh University and completed her PA training at Temple University. She started her career in urgent care, but thankfully for all of us, she transitioned to neurosurgery at GNI, and she now serves as the APP co-lead for outpatient services. During her time at GNI, she also completed a Doctor of Medical Science degree, and she played a key role in developing the Chiari Center of Excellence. Anybody who's been involved with the Chiari Center of Excellence knows that Haley is the force behind it. She runs the support group, all the events that we do. She is truly done wonders with that. In addition, she's an advanced stroke life support instructor. She's the co-director of the GNI Drexel Neurosurgery PA Fellowship, and she's an active PA student preceptor. Haley, thank you for joining us today, and we look forward to your talk.
Thank you, Dr. Rami. I appreciate it. I'm going to share my screen here. Okay. Can you see that?
We can, yes.
Okay, perfect. All right. Thank you again. I appreciate the introduction. And I'm really excited to talk about what we're doing with the GNI Center for Chiari and Syringomyelia, especially as we're coming off of Chiari Awareness Month, which was in September. So I'm going to start off by first doing something interactive. I know it's Friday morning at 8 a.m. So, some of you might be groaning, but luckily I can't hear you. But if you could just use this QR code and just scan it, and it'll take you to this URL. It's classpoint.app. And we just have a couple of questions to go over in the very beginning. And I promise there's a reason to my madness here. And all of the answers will be anonymous as well. So you can see some names popping up, but as we go through the questions, it'll more so just be a general poll for everybody. And if the QR code isn't working on your phone, you can also just type this URL into Safari or Internet Explorer and type in the class code listed below. Okay. As people are signing in, we'll start the questions. You can continue to join. It'll show you the class code as we go through the questions. So if you're still working on it, don't worry, you can still participate. So the first question I have is just kind of to gauge, who we have joining today. And I apologize, they only gave me 8 options here. So if none of these describe you, I apologize. But you can always hit the H option, which is other. So what best describes your role? You should see the options come up on your phone now. Okay. So kind of a wide variety of participants today. We have some neurosurgeons, we have other physicians, we have, let's see, E is advanced practice providers, either PAs or NPs, some allied health professionals, and other. And then next is, do you typically see Chiari patients in your practice? So on a day-to-day, how often are you seeing Chiari patients? A, yes, regularly. B, occasionally. C, rarely or never. And D, not applicable. Okay, perfect. And responses are trickling in, but you can see a pretty wide range. So some regularly, some occasionally, rarely, and never. So we have the wide spectrum here. We'll close this submission. And then lastly, what is one word that comes to mind when you think of Chiari malformation? Great. So you can see they get bigger if there's more responses associated with them. So complex, complicated, misunderstood, debilitating, headaches, it's a big one, CSF, rare, spectrum, painful. These are all great responses, and it'll become more relevant later in the talk. But goes to show, why we're talking about it today. It's a complex diagnosis. I'm going to close the submission here. And I appreciate you guys participating. There's no more questions, so you don't need to stay on that app on your phone. But it's going to be important later on when we look at some of the responses that we saw in our Chiari support group. And I'm not going to go too much into what Chiari is, but for those of you who might not see Chiari too much, I'll do a little bit of a background just to go over what it is and how we treat it. So Chiari malformation was first described over 120 years ago. It since has been subclassified into different types. So we can see here Chiari 1. What we're describing is a downward displacement of the cerebellar tonsils into the craniocervical junction, so below the level of the foramen magnum. So when this happens, it can obstruct CSF flow, which you would see in the blue, and cause symptoms. With this obstruction, sometimes what can happen too is the CSF that is normally flowing freely here can take the path of least resistance and create a CSF-filled cavity within the spinal cord. There's even more classifications that have come up over time. Chiari 1.5, also including the brainstem in this downward displacement. Chiari 2 and 3, which we see more so in our pediatric population. Chiari 2 is often associated with a myelomeningocele from failure of fusion of the neural tube during embryogenesis, which creates a fluid-filled sac that contains part of the spinal cord, the nerves, and CSF. Then Chiari 3 often is included with an encephalocele, which involves the protrusion of brain tissue and meninges. And then type 4, which is rare, but it's often associated with an absent or underdeveloped cerebellum and often is fatal. Then with all of these, even more recently, there's been descriptions of a Chiari 0, which is very heavily debated. But basically what this means is that there's no cerebellar tonsillar descent, but there's crowding in the posterior fossa and symptoms. So for the purpose of this talk, we're really going to focus on Chiari 1, which there's also debates on whether it's 5 millimeters, 3 millimeters of tonsillar descent, and there's also nuances with age, but what we're going to focus on is the radiographic finding of 5 millimeters of cerebellar tonsillar descent. So that's 5 millimeters from the level of the foramen magnum. So symptoms that are associated with Chiari malformation, they typically, the most common symptom, which I think was touched on in that word cloud, is headaches in the back of the head, so occipital headaches, and that's typically worsening with Valsalva, meaning anything that can cause increased intracranial pressure. Maybe it's coughing, sneezing, bending over, bearing down, or going to the bathroom. All of these things can cause worsening of these headaches. You might also see neck pain, balance issues, muscle weakness and numbness and tingling, and that's particularly with the association of that syrinx that we talked about. There'd be dizziness, tinnitus, which is ringing in the ears, and some hand coordination issues, plus more, which we'll get into in a little bit. When they come into your office, some of the things you might see on physical exam, nystagmus, dysarthria or dysphonia, like speech issues. Then you might notice abnormalities in gait. So whether they're walking to the exam room or whether you have them go out into the hallway, you might see changes in gait. A lot of times patients will say, oh, I'm noticing that I'm like bumping into walls. Dyspmetria or intention tremor, you can have them do like finger to nose and see whether there's any abnormalities there, whether there's any tremor when they outstretch their arm and hand. And then some syrinx related symptoms. You can see motor weakness, especially in the upper extremities. And then you might see hand muscle atrophy. So, you know, if they're complaining of grip strength, if you notice grip strength weakness, look at the hands and you might see thenar atrophy. And then sensory, there's loss of pain and temperature, which has been described as a cape-like distribution, but honestly, it doesn't have to be in that specific distribution. But there can be sensory loss, especially with the syrinx. And then the way that we decide whether surgery is indicated is based off of a bunch of different things. So one could be the severity of the symptoms. Typically, if it's just headaches that they're complaining of, you know, we're going to kind of work up the headaches before automatically jumping to surgery, because oftentimes they can have like migraines or other types of headaches, and we want to really rule that out before doing something permanent like surgery. Their level of disability, whether they have a syrinx, and that's a big one, because that indicates that there's an obstruction of flow. I put a picture over here of one of our patients that had a pretty significant syrinx, and as you can imagine, significant physical exam findings from the syrinx that required surgery. And if it's not as obvious, then what we can do is a cine flow, which is, I think I have a picture here, a study that looks at, it's a specialized type of MRI that captures multiple frames within a cycle of CSF movement, creating a video of CSF flow. So the goal of surgery is to restore flow to that area, right? So this video is a great tool for our neurosurgeons to look and say, okay, is there flow or not? Will surgery help or not? And then ultimately, if they are a surgical candidate, they would undergo a Chiari decompression most commonly. There are other nuances where if there's suspected underlying hydrocephalus, they might undergo a VP shunt. But for the purpose of this talk, we'll go over the most common resolution, which is the Chiari decompression surgery. So there's nuances. Different neurosurgeons might do this a little bit differently, but typically there will be a linear incision in the back of, basically at the base of the skull where this dotted line is. And then a C1 laminectomy would be performed to open up this area, sometimes C2, but most commonly just C1. And then a suboccipital craniectomy, which means a piece of the foramen like where the area of the foramen magnum, a piece of this bone will be removed to open up that obstructed area. And then the dura would be open to shrink the tonsils to restore flow. And then typically the dura would be closed with bovine pericardium. And then, so sounds simple, not quite. Actually, if you're like me, you're probably like nothing about performing neurosurgery. Sounds simple. I'm not a neurosurgeon. I can only imagine that, you know, all of these cases are difficult, and luckily we have a great team of neurosurgeons who are experts in Chiari care and do these frequently and know how to do them properly and efficiently. But for me, it doesn't sound simple. But you might be saying, you know, look, Haley, you've described the symptoms, you've described the signs, you've showed what the imaging would look like. Why is it so different from any other type of neurosurgical complaint? And there's several reasons as to why it stands out. So one, there's anatomical variability, right? So there might be different levels of cerebellar tonsillar descent, but not the extent of the descent doesn't equal the severity of symptoms. So somebody who might have 1 to 2 centimeters of cerebellar tonsillar descent might be completely asymptomatic. And then vice versa, somebody with 5 millimeters of tonsillar descent might have every symptom that we talked about. So it's really tough to, just look at the imaging and know what type of symptoms they might have. And then there's also the CSF flow dynamics. So we spoke about how obstruction of flow is a big factor here, but this can change with posture, exertion, Valsalva. So if somebody is doing an MRI, which is the mainstay of how we diagnose a Chiari malformation, they're typically lying flat on their back. But if they're standing up, gravity might cause that cerebellar tonsillar descent to increase. And if they're bearing down with imaging, that might also show a little bit more of descent. And then there might be underlying hydrocephalus, which is sometimes hard to decipher, and might require a shunt even after Chiari decompression surgery. Also, there's heterogeneity of symptoms. So people come in with, different combinations of the symptoms that we spoke about. And there's overlap. I kind of touched on that with things like migraine. So you want to make sure to fully evaluate for migraine so that you're not recommending surgery for somebody that just needed medications and could have been treated conservatively. Additionally, it's sometimes has an unpredictable natural history. So we see these symptoms most commonly occurring, in late childhood to early adulthood. But what we're finding more and more is that, the prevalence is estimated to be about 1%, but as we do more MRIs for different things, it's becoming, we're finding it more often, and it might be completely incidental, but somebody might come into the office with no Chiari symptoms, but it's difficult to say like if they will ever develop symptoms. And one of the main things that is often overlooked is that we're now finding that there's cognitive and psychiatric symptoms that are associated with Chiari as well. So most studies that have been coming out report evidence of cognitive dysfunction, but with variable impact across domains of attention, processing speed, executive functions, episodic memory, and visuospatial skills. There's also been evidence of psychiatric comorbidities, mainly anxiety, depression, and there have been cases of panic disorder and bipolar disorder. But unfortunately, there hasn't been a lot of research done in Chiari. We're noticing this more and more, and luckily there are more and more papers coming out, but it's still pretty understudied compared to some other things. Another thing that people debate pretty heavily is, we have spoken about the headaches, the pain, that even came up in the word cloud, that pain is a big aspect of Chiari. So is pain causing the psychiatric comorbidities. You can imagine if you're in chronic pain, you're likely to have depression, anxiety. You might also have cognitive symptoms as well, because if you're in pain, it's hard to pay attention to things throughout the day. You might not comprehend things as well. You might be in a fog, which a lot of people describe. So, it's hard to say what's the chicken and what's the egg, but we've had some studies come out with differing viewpoints. So the top row here, you can see that these findings typically has shown that cognition and depression, anxiety is associated with chronic pain. And then the studies below have controlled for pain and find some differences and deficits in those areas. But a big thing to look at here is that it kind of shows, how little research is being done. You can see that it's the same groups in each of these categories, really, that we're looking at these things. So you can see similar names in the top row and similar names in the bottom row, which is no knock to these groups because they're doing the research that we need, but we need more people to be looking at this to definitively say, what is truly associated and is pain a big culprit. So right now, the answer is we don't know. But what we do know is that the cerebellum is associated with cognitive and affective symptoms. So the term cerebellar cognitive affective syndrome was coined in 1998 after advances in imaging modalities provided evidence of the cerebellum's role in spatial, executive, affective, and linguistic functions. So this group looked at patients with insults confined to the cerebellum only and found disruptions of cerebello-thalamo-cortical pathways leading to cognitive and affective changes. So this shows us, cerebellum's role goes beyond motor coordination. And if you think about Chiari with the cerebellar tonsillar descent and pressure on the cerebellum, you would think that there would be some cognitive and affective symptoms just from that anatomic malformation. These are some of the studies that have been done to kind of prove this. So you can see there's fMRI has been used to show patterns revealing cerebellar activation during language and spatial tasks, which are different from the areas over here in the motor tasks. So you can see different parts of the cerebellum is activated when they're giving these tasks associated with language functions, spatial awareness, and that's in a different area than the motor symptoms that we normally associate with the cerebellum. And then on the right, we showed that the resting state functional connectivity shows that the cerebellum is part of resting state networks supporting cognition, including frontoparietal control networks, which is in the orange over here, and dorsal and ventral attention networks, which is in the green and violet areas. But unfortunately, very few studies have looked into correlating neuropsychological performance compared with advanced techniques like EEG, fMRI, and diffuse tensor imaging. There's some. So you can see here, I pulled this figure from a study that did fMRI in Chiari. Looked at 18 patients compared with 18 age and sex matched controls. And it shows that Chiari does alter brain networks. So resting state fMRI showed both hypo and hyper connectivity between the cerebellum and cerebrum versus controls. Some differences did vanish after controlling for pain, yet the posterior cerebellar pathways remained abnormal. So the clinical takeaway from this study was that, it supports intrinsic cerebellar network dysfunction is seen in Chiari, and that, we need to screen and treat things that, symptoms of attention issues, mood and anxiety, and sleep and pain symptoms as core disease features, not just comorbidities. So what we really want to get to today is update, what we're doing at the GNI Center for Chiari and Syringomyelia. So, you might say, why create a center of excellence for Chiari patients? So really, we just need to ensure that we're addressing all of these symptoms, which requires multi-specialty care, right? It's hard to address all of these things in a new patient appointment. So it really needs to be a coordinated care to make sure that, one, patients are being screened for some of these other symptoms, and two, that they're getting the resources they need. So this might look familiar. We actually asked the same question in our Chiari support group. So what is one word that comes to mind when you think of Chiari malformation? They did the same thing. And you can see some overlap in words. Misunderstood, pain being the big one, headache. We saw those in the survey that we asked at the beginning. But there's other ones here too, right? Misunderstood was one of the most common ones. Limited doctor knowledge, miserable, isolation, confusion. So you can see that these patients are not only suffering, but also scared, and they feel alone. I mean, we said the prevalence is around 1% of the population, right? So they might not know anybody with Chiari. They might think that they're the only ones with Chiari, and they don't know what to do next or who to talk to about it. So not to be super negative on a Friday morning before the weekend, but more reasons why Chiari care fails patients. The average time to diagnosis is around a little over 3 years. So if you can imagine, we spoke about how much pain is involved in this diagnosis. 3 years is a lot of time to take to not know why you're in so much pain, right? Or you might have all of these weird symptoms. You might be going to different doctors. They might be saying, oh, it's this, and somebody else might be saying, oh, it's that. And, you lose trust in the healthcare system, and you get a little bit, I want to say, you lose a little bit of hope just because you're being told all of these different things. And, you can just go onto Google and Reddit and read about people who have a symptomatic Chiari malformation and how long their journeys might be. It can take up to 20 plus years in some people. And, it's also tough because there's differing diagnostic criteria. We spoke about differing levels of cerebellar tonsillar descent. We spoke about Chiari 0. Not everyone agrees on these things. So they might go to one neurosurgeon that says one thing, and then a different practice that says something completely different. And then there's little attention to those higher order cognitive functions and some psychiatric comorbidities. They might not have time to address all of these things or screen for all of these things in an appointment, when really you're looking to decipher whether somebody needs surgery or not. So oftentimes that might not even be included in the workup. And I've already said several times, but there's minimal research. So we're still working these out, or working out some of these different factors, even though it was first described over 120 years ago. So the takeaway from this is, motor and sensory symptoms are frequently the focus, with little to no attention to higher order cognitive functions. So what do? We listened to the patients and decided we need to provide more comprehensive care. So we wanted to create a center that used all of our resources to attack all of these different things. So not only is that neurosurgical intervention, which we have excellent neurosurgeons both in the adult world and pediatric world that are trained in Chiari care, but we also pull in some other people, right? Some research, community outreach, rehab and functional sports, PTOT, neuropsychological testing for those cognitive and affective symptoms, and then mental health services. So here's some of the people that started the center. We have Dr. Vez and Dr. Rami, who our neurosurgeons and Dr. Lovin as well, who's our pediatric neurosurgeon. We have Dr. Kate Lester, who's our neuropsychologist, Dr. Ross, who was the director of research, Dr. Mitzi Grant, who is our neuropsychologist over at St. Chris, and then Olivia and I were some APPs that also provide support to our patients. So it's a multidisciplinary approach. And this is not all encompassing. We also work with, our partners in PT, mental health services, and, other specialties, neurology, to make sure that we're providing comprehensive care. And why do we do this is to improve communication. We meet monthly and not only discuss research, but also talk face-to-face about different aspects of patient care. This allows us to make comprehensive decisions and personalized care plans, identify whether there's gaps in care, and apply resources if needed. They might need, a neuropsychological evaluation. They might need PT. They might need mental health services. And this improves communication. So, instead of maybe saying, okay, go see the neuropsychologist, and we just read the note later, if there's any type of concerns, we can all get together and talk about a case, which is really helpful to kind of bounce ideas off of each other. And then ultimately research and quality improvement, making sure that we're providing the best care to this population. So the way that we do this is kind of like the overall flow, although there's nuances to this, especially because, they might come from different areas, whether it's, they're incidentally found to have a Chiari and their PCP is referring them. They might come in for headaches to see one of our neurologists and get referred to neurosurgery. But generally what happens is they will have a neurosurgical appointment, and we provide them with an intake form. And that goes over some of the symptoms of Chiari, including those cognitive and psychiatric symptoms. And we'll go into more detail about what that form includes. And they'll get the surgical evaluation, decide whether they're a surgical candidate or not, and decide whether they need other resources like PT, OT, speech before and after surgery. Pain management is a big one, as we spoke about pain a lot. And then if something is, coming up on their screening intake form, they might need neuropsychological review to look at those cognitive and affective symptoms. They might need mental health support. And then research is kind of like an aside, that's going on in tandem with all of these things. So what we're hoping to do is more research so that we can refine Chiari care and improve outcomes in the future. So I just want to go a little bit into the intake form. We won't go in a lot of detail, but it's a form that all of the new Chiari patients will complete, and it takes anywhere from like 10 minutes to maybe 30, 40 minutes. They can do this online. They can do it in person, in writing. And typically we have one version for the pediatric side and one version for the adult side. Pediatric form is done with a parent or family member. The adult form can be done alone, or oftentimes we encourage them to do it with a family member, just because sometimes the family members will notice, especially with the cognitive symptoms, some things more than the patient might themselves. So the first page will start with like an educational behavioral review. So this is some things that are touched on the pediatric side. A lot of things involving school, whether they had any issues in school, whether they needed any type of support, whether there was attention or behavioral concerns, whether they did any specialized programs, whether they had ADHD or emotional behavioral therapy. And this the purpose of this is just to capture the academic impact of Chiari and whether school-based accommodations or therapies are in place. Then we have the adult form. So this first page, pediatric wouldn't complete this. This is just the adult version. And it goes over some of the same things, but also goes into work history too. So how much school they completed, whether they had any issues in school or at work, whether there's any attention or behavioral issues that interfered with their performance, if they had any accommodations. And really what we're looking to do is to document long-term impact on education and employment, as well as ongoing functional supports in adulthood. Next, we go into 3 different sections. So the first section is a psychiatric screening, and there's 11 questions. They will be prompted with a bunch of different scenarios, and they will score them from 0 to 3. So 0 being this never happens, 1 being several days, 2 meaning more than half the days, and 3 nearly every day. And they're looking at the past 2 weeks to decipher whether any of these things have affected them. We'll go into some specific prompts later, but really what this does is look at mood, sleep issues, appetite, suicidal ideation, anxiety, specifically for Chiari. So it was adapted from the patient health questionnaire, but also included some things for anxiety too, to make sure that we're encompassing, both signs of depression and anxiety, which we're seeing in the research for Chiari. And the total possible score, if they say 3 out of, for every single question, would be a 33. Then we have the cognitive screening. So there's 20 questions in this section. And you might be saying, okay, well, if somebody has cognitive deficits, how are you screening it from a self-reported assessment? It's not really, the purpose of this intake form isn't to diagnose anybody. It's more so just a screening tool to decipher whether they need resources or not, or whether they need further evaluation. So this might throw a red flag and say, okay, maybe they need neuropsychological testing. So this looks at the DSM-5 cognitive domains, and it was adapted from different cognitive screening tools. Again, the scale is 0 to 3, and it looks at issues with memory, attention, concentration, executive function, processing speed, language, visuospatial skills, coordination, and combined thinking and movement tasks. So this was really just to help us screen in conjunction with what we're seeing in physical exam in the office, because you might pick up on some cognitive deficits in the office as well, or ask specific questions and see if there's anything that the patient might indicate that would suggest that there's cognitive concerns, especially things like brain fog, which a lot of patients will describe. And this total possible score, if they score 3 for everything, is 60. And then lastly, we have the functional screening. So that's 8 questions, again, scored from 0 to 3. And it's really just looking at activities of daily living, whether they're able to perform these by themselves, such as like using a telephone, shopping, cooking, maintaining the household, laundry, transportation, and whether they're able to manage their own medications and finances. And this might let us know, whether they need PT, OT support before and after surgery. And the total score for this is 24. So we've had 48 patients respond to these forms so far. I pulled out the prompts that score the highest. So when we look at the psychological assessment, we ask patients to think back to the past 2 weeks and score 0, meaning it never happened, 1, several days, 2, meaning more than half the days, and 3, nearly every day. And these are the things that scored the highest. So trouble falling asleep or staying asleep or sleeping too much. 46% of the people who responded say that it happened more than 50% of the time. So a 2 meaning more than half the days, 3 nearly every day. 46% said at least more than half the days. Feeling tired or having little energy, 52% responded more than half the days. And then feeling nervous, anxious, or on edge, 46% again responded more than half the days. So when you think about it, sleep disturbance, difficulty falling or staying asleep or hypersomnia is common. In Chiari, it can be due to pain, poor sleep hygiene, or sleep disordered breathing, including central and obstructive sleep apnea from brainstem involvement. With fatigue or low energy, also likely multifactorial, could be inadequate sleep, sleep apnea again, chronic pain, mood, and neurologic dysfunction can all contribute. And then anxiety and nervousness might be secondary to chronic symptoms and uncertainty, but as we're seeing in the research, it could also be a direct manifestation of Chiari due to cerebellar and brainstem involvement in mood and autonomic regulation. But what I thought was important to note here was that none of the respondents scored a 0. So, causation is obviously complicated, but the need for support is very, very clear. Then in the cognitive assessment, these are the ones that scored the highest. So do you struggle to sustain attention on specific tasks without becoming easily distracted? Again, they respond either 0, being never, 1 sometimes, 2 often, or 3 very often. And 39.6% scored a 2 or higher, meaning this happens often or very often. And then we saw the same percentage of respondents scoring that way for, are you having trouble concentrating on tasks or maintaining function for extended periods? And this makes sense, right? Because attention and concentration are some of the cognitive domains that are most affected in the Chiari research that has come out thus far. Then lastly, functional assessment. I would say that, and we'll see the trends in the next couple of slides, but functional assessment, the scores weren't as high, but I pulled the ones that were the highest, and it was housekeeping or maintaining your living space and then doing laundry. So for both of these questions, 27.1% responded above a 2 or 2 or above. So that means often or very often. And you might think about this and say, is it related to that decreased attention and concentration? They're not able to do these tasks throughout the day because they're not able to stick with it. Is it symptoms related to the headaches and pain, or maybe they have, the grip strength weakness and difficulty with hand coordination, as we spoke about before, that causes them to have difficulties with these tasks? It's tough to say, but we can allocate resources like PT and OT to help with these things if their screening is very high in these areas. And so out of the 48 results, I filtered it down by just adults, 16 years or older, and the people who meet that diagnostic criteria of 5 millimeters of tonsillar descent or above. And these are the raw scores. So psych is a full score out of 33, cognition out of 60, and functional assessment out of 24. And you can see the wide range of results here. And you might be thinking, oh, well, those bars in 0 to 3 are extremely high. But you have to remember also that we're giving this intake form to every single person that's coming in with the chief complaint of Chiari. So this includes people who are completely asymptomatic as well. So what I did was look at patients who were recommended surgery versus those who were not, to kind of see how the scores differ. And what we're seeing is that the mean score is increased in all 3 of the sections. And the data isn't statistically significant, might be due to the small sample size, but we're seeing these trends, which is notable. And it shows us that patients with Chiari who are recommended surgery had more symptoms of anxiety, depression, cognitive issues, and functional decline. So it's important to note these trends when considering, the treatment of patients. And again, causation is complicated, but the need for support is clear. So I thought what I would do is kind of walk through a case of somebody who went through this whole process through the Chiari Center, just to see how we allocate different resources depending on the person. So we had a 25-year-old female who came in with a chief complaint of Chiari malformation, past medical history, GERD, depression, had the occipital headaches or the headaches in the back of the head, worsening with Valsalva, dizziness, balance issues, tingling in the fingertips, tinnitus, memory issues. And then on exam, they had bilateral grip strength weakness. The MRI was done. It showed, per report, 1 centimeter of cerebellar tonsillar descent. And then a cine flow was done, which showed obstruction of CSF flow. We did the intake form. These were the scores that she had, 29 out of 33 for psych. And we know that she had diagnosed depression, right? So it's not completely surprising that she might score high on the psych section. Cognitive was 20 out of 60, and then functional is 16 out of 24. In the psych section, the high scores were primarily little interest or pleasure in doing things, feeling down, depressed, poor appetite, trouble concentrating, feeling nervous or anxious or on edge, but there was no suicidal or homicidal ideation. Cognitive, the main issues were issues with memory, concentration and focus, attention issues, executive function, and some issues with processing speed. And then functional, she had difficulty shopping for groceries, cooking, housekeeping, laundry, managing medications, and finances. So, we saw there were some concerns for cognitive and affective symptoms, so we had her undergo formal neuropsychological testing. And what this showed was there was mild reductions in complex mental tracking, mental flexibility, organization, and memory. The pattern of these findings suggested disruption of frontal subcortical networks, which is nonspecific in origin. And like we've been saying before, the etiology was suspected to be multi-determined. So could be due to her known diagnosed depression, acute stress, poor sleep, pain, or could be due to the Chiari malformation. She did ultimately undergo Chiari decompression, but what we also did, because she came through the Chiari Center, was we allocated some resources to help improve her outcome. So she was connected with psychiatry already due to the depression. So we spoke with her psychiatric team. She was recommended to undergo cognitive therapy due to her neuropsychological results. She was connected with PT and OT, and actually she was given a shower chair to help her after surgery. She was connected with sleep medicine due to the sleep symptoms that she was complaining of. And she's a part of our support group. So when you think about it, you might not have had time to screen for those things if it weren't for the comprehensive intake form that we give all of the patients. So now she has the resources she needed to improve outcomes. And what we're hoping to do with this research is compare intake form data with the neuropsychological testing to gain some validity, and then ultimately compare scores before and after surgery to see if decompression helps with those cognitive and affective symptoms. And this will help us explore predictors of improvement and then hopefully continue to build a longitudinal outcome registry. Some of the other research that we're doing with our group is looking at medicinal marijuana for pain in patients with Chiari malformation. This was funded by ASAP, which is the American Syringomyelia and Chiari Alliance Project. And what our group noticed is that, opioids was really the only effective pain management strategy for patients with Chiari, but some Chiari patients were using marijuana to help with pain. So what we wanted to do was define, look at different factors to consider, whether it be frequency, route, or strain, to see what works best for patients. So again, looking to define marijuana consumption habits, and the way that this was done was by giving a survey out to patients, which included general information, consumption habits, and pain/quality of life before and after consumption. We obtained IRB approval and used a HIPAA-compliant survey platform, gave patients like a QR code, either through the ASAP or when we saw patients in the office, and they answered these questions online. And the results, 52 surveys were completed, and the age range from 31 to 60, 61% of respondents reported using it multiple times per day. The preferred strain was the indica and hybrid strains, and the preferred method was inhalation. And what's really important to note here is that 63% reported stopping or lowering doses of medications since starting marijuana. So that's huge, right? If you're considering marijuana versus, long-term opioid use, the patients were showing that they required less of those pain medications with the use of marijuana. And you can see here that people who reported reduced pain, about 40% reduced pain after using marijuana was the major category here. Then you saw 60% reduced pain, some people reported, and then 20% was also a big category. So almost like 50% of their pain was reduced after using marijuana most commonly. And when you think about those other symptoms we've been describing, right, the mood, anxiety, you can see here that in addition to the pain relief, which was typically moderate to strong, they're also reporting mood elevation, moderate to strong, and decreased stress. So it can also help with those other symptoms that we've been describing as well. And the conclusion of this study was that it is effective in pain with patients with Chiari, and specifically indica being the strain, which provided the most pain relief, with inhalation being the preferred method. And then what we'll go into now is just, in addition to the research and to the resources we're allocating, we're also doing some community outreach as well. So every month on the first Wednesday of the month, we do Chiari support group at 6 p.m. It's virtual. We've been doing it for about 2 years now, which is crazy because it doesn't feel like it's been that long. But we just had one this past Wednesday, and we did innovations in Chiari care. We get about 50 to 70 people sign up for these Chiari support groups, and it's really great because in addition to doing specific topics per month, it just goes over whatever the people who join request. Like, we will go over different topics. We'll have other guest speakers on, typically depending on what our surveys afterwards ask for. But they also will talk about, their journeys and with being diagnosed with Chiari and what helped them. And we're really creating a community and a network within the support group. And you can see on the right, these are the areas that we've been seeing have been joining each Chiari support group. So we've had people from not only the US, but Canada, Mexico, the UK, India, Australia, New Zealand. And this might not even encapsulate everybody, but when we've asked, where people are joining from, these are some of the areas that have been reported. And, that's not just to say, oh, we're we're doing great things here, but it also shows that there's just not a lot of support groups, right? Like people are searching for different things. They might feel alone in the diagnosis and they might not have anywhere else to, speak with somebody who might be going through similar things. So we're getting a wide network. When we asked people who were joining, whether they would have any type of advice for somebody who might be diagnosed with Chiari, these are some of the things that were said. A lot of it had to do with finding the right provider, somebody who's actually aware of Chiari and the different aspects of Chiari and how complicated it is. Seek an expert treatment center. Your best advocate. Join Chiari groups. And there's other ones out there, other support groups out there that they are able to join now. And luckily, these are becoming more and more frequent, so they might have different options. And you can see the top left, somebody's Chiari journey was 10 plus years, and they were dealing with these symptoms and wish that they had answers sooner. And then we do different events. So we did this past May, we did the Chiari Center for Chiari and GNI Center for Chiari and Syringomyelia Run, Walk, and Roll. It was a 5K. We had everyone join between patients, providers, different members of the community, all came together to raise awareness for Chiari and Syringomyelia. So it was a great event. We had somebody run like a 5-minute mile or something, which is absurd. But people were walking, people were just, helping out and volunteering. Really, it was a great turnout. I think there was upwards of 70 to 80 people who joined us. And shameless plug, we'll be doing it again next year. So if you're interested, please stay tuned because we'll have more information about that in the beginning of 2026 for May. And that ends my talk. This is my dog, Douglas. He also participated in the 5K, but got a participation medal, even though he only walked like 100 feet before tapping out. So
yeah. Typical golden retriever.
Yes.
Haley, thank you. This was a phenomenal talk, and just for anybody who's not familiar with the Chiari literature, to have 45 patients included is beyond anything you can find in the literature. This is phenomenal work. We appreciate everything you've done and you continue to do. We're coming up to the end of the hour. I just want one quick question. For people in the community, for primary cares or for just family members of Chiari, what's the best way for them to get their loved ones or themselves plugged into one, a clinic in our Chiari Excellence Clinic, and two, into the support group?
Yeah, so you can get information, one, for our support group, either through our social media platforms. We're at GNI Neuro on Instagram, Facebook. We always post about the Chiari support groups like a week in advance, and there's links to sign up. You can also go to our website, www.gnineuro.org. There's a section there for support groups as well, not only Chiari, but stroke. And if you're looking to be evaluated for Chiari, you can always, one, call our office, which the information is on that website as well, to make an appointment, or contact us through there's emails on the website as well. And if you say that you're coming in for Chiari, we'll make sure to plug you in to our Chiari Center of Excellence.
Perfect. Thank you very much. We're at the top of the hour again. Haley, thank you so much for the talk and for the tremendous work you're doing with the Chiari. I know I see a lot of patients in my clinic with Chiari, and they all love you, love the work that you're doing, and they all are very thankful for the significant change that you're making in their lives with the support group and with all the work that you're doing. It's a lot of heavy lifting that you're doing up front. It's easy to come at the end and say, "Oh, look, we have data now." Where no one said you actually are doing all the heavy lifting from the start up, and I commend you for putting all the effort and for the results that are coming. Thank you. And
I
thank you
appreciate
everyone
it.
for
It's
joining
not
us.
just me, though. I
I,
do
I
have a
know
team
where it's a
behind
whole
me.
team, but I think you're the face of it. You've done all the heavy lifting behind Dr. Vez. Obviously, is the head of the group, but so everybody's doing a phenomenal job, but the job that you're doing is also phenomenal, and they all love what your personal touch to them as well. So. Thank you very much for all you do for our patients and for the community, and thank you everyone. We'll see you for our next grand rounds.
Thank you.